Thank you. I'm pleased to be here. It feels like old home week getting back with Dr. Joe Munzer. He and I were together at University of North Carolina for a few years before I got lured away to Cincinnati. I want to talk about problems with airways in people with mucopolysaccharidoses. Everybody understands that breathing is a rather important thing to do. Our airways conduct air. We start with the nose. The nose filters the air that we breathe. It warms the air as it flows through, and it also humidifies the air that we breathe. Then we have the larynx, our voice box, if you will. And the voice box consists of vocal cords and associated structures. They produce our sound of our voice, but they also protect our airway because the vocal cords close tightly when we swallow. And then we reach the trachea, or the windpipe, that carries air to the lungs. We talk about the tracheobronchial tree, the trunk and the branches. The trachea is the trunk of the tree. The bronchi are the branches of the tree. In the human lung, there are something like 22 to 25 generations of branches before we reach the alveoli, which are the small air sacs where the blood takes up oxygen and gives off carbon dioxide. There are something like 300 million alveoli in our lungs. They're very small. They're very much like the branches of a tree. Now, I want to take you on a guided tour of the normal human airways, beginning at the nose. So here we are entering the nostril. The nose is not just an open pipe. It's got a bunch of things in it we call turbinates. They increase the surface area for moisture exchange and humidification. In the back of the nose, we have a little pouch over here that goes to the middle ear. The soft palate is up here. This is the back of the throat. Here is the base of the tongue. This little structure is called the epiglottis. It's like a toilet seat lid that folds over our larynx when we swallow. And here are the vocal cords. Two structures I didn't have time to talk about are called the arytenoid cartilages, the muscles that move the vocal cords attached to these two cartilages, which you see back here at the back of the vocal cords. Those become very important in people who have mucopolysaccharidoses. Okay, so now we're in the trachea, and you can see these rings of cartilage that support the trachea and give it pretty much of a round shape. The back wall is muscle. And here we get to the bottom of the trachea and go into the right lung. And here is the right upper lobe. And you can see as we go further out, there are more and more branches that become smaller and smaller. So every time we breathe, we pull air into the lungs. It goes through these conducting airways out to the alveoli, delivering oxygen to our blood and carrying carbon dioxide away from our blood. Now, I like to talk about the ABCs of human survival. A stands for airway. Without an airway, you cannot breathe. And if you cannot breathe, then nothing else matters. A, B, C. Airway, breathing, and then all that other stuff, the heart and the brain and the whatever. None of it works without an adequate airway and the ability to breathe. So airways and lungs are pretty important for our function and survival. So now let's talk about what happens when our airways become obstructed. We all have some form of airway obstruction from time to time. What happens when you get a cold? Your nose gets all blocked up due to mucus and swelling of those turbinates that we saw, and it gets much harder to breathe, and so we breathe through our mouth. And when we breathe through our mouth, we bypass the nose, so we can't smell mama's cooking, but we also do not warm and humidify the air as it goes into our trachea and down into our lungs, and so it becomes more irritating, and that aggravates our cough. Anything that physically obstructs the airway can be made worse by increased secretions, as in a cold, or by swelling, both of which we get when we get an infection like a cold or, even worse, the flu. Now, how do we get air in and out of our lungs? You know what a bellows is. You expand the chest and you create a vacuum, and that pulls air into the lungs. When we exhale, we compress the chest and we push the air back out of our lungs. In general, any obstruction above the top of the chest results in obstruction mostly during inspiration, while we are breathing in. Good example of that is snoring, and I don't need to reproduce that sound for you right here. It would be rather rude, I think. Obstruction below the top of the chest results primarily in obstruction while we are exhaling. And a good example of that is wheezing, as in someone with asthma. Airway obstruction can be fixed. The obstruction can be rigid, or it can be dynamic obstruction due to a structure that is very floppy. Now, patients with mucopolysaccharidoses of all sorts, but predominantly those with types 1 and 2, tend to have a high frequency of airway problems. And let's talk about what some of those problems might be. One of the most common is enlargement of adenoids and tonsils. Well, just like lots of other kids who don't have MPS 1 or 2. But in our patient population, they tend to be a little bit worse than in otherwise healthy children. They can lead to significant problems. Many people, and again, particularly types 1 and 2, many people with MPS have a very floppy larynx. I'll show you some pictures of this in a moment. We call this laryngomalacia. You all probably are well aware by now that we have $17 words for just about everything in medicine. This is no exception. Laryngomalacia simply means a floppy larynx. It's fairly common in healthy newborn infants, and the symptoms tend to go away in the first 6 months, a year, year and a half in most of these children. In children who have MPS, particularly 1 and 2 more than 1 even in my experience, they tend to develop increasingly severe laryngomalacia as they grow older. There is also a problem with deposition of mucopolysaccharides in the tissues lining the airway. This can result in narrowing of the trachea, very much like boiler scale in a pipe. It can also obstruct the airway in the upper airway as well as in the lower airway. So let's talk about airway obstruction per se for a moment. The most common manifestation is going to be simply noisy breathing, particularly when the obstruction is dynamic. The faster air flows, the less pressure that air exerts to the sides, and so things tend to collapse around a stream of flowing air. And if the tissue is floppy, it's going to become even more floppy, and it's going to vibrate during inspiration and cause what we call stridor. Snoring is another example of inspiratory airway obstruction, typically caused by vibration of the soft palate or the side walls of the back of the throat, or of the tonsils. Shortness of breath with exercise is a common manifestation of airway problems, airway obstruction due to a variety of things. And then there is obstructive sleep apnea, and this can be quite serious. Obstructive sleep apnea is irregular, gasping snoring. If you hear snoring that is monotonous, it's the same sound with every breath, and there's no pause. It just keeps going on and on and on. It's snoring. As Ann Landers replied to the lady who wrote complaining of her snoring husband, "Relax, dear. You know where he is. You know who he's with, and you know what he's doing." So when your child is snoring and it's monotonous, you know where he is and you know what he's doing. And it's probably not going to be a significant problem. But if the obstruction reaches a point where at times the airway becomes completely obstructed, guess what? There's no sound. And so you hear a snore, a snore, a snore, a pause, and then a big gasp as the child awakens and stretches out to open up his airway. Snoring with pauses and gasping, if it's consistent, needs to be investigated medically. Because obstructive sleep apnea can cause significant problems. In addition to the frequent awakening and arousal, the quality of sleep becomes impaired. The oxygenation can be bad. There can be carbon dioxide retention. Many of these patients will have excessive daytime sleepiness. They do poorly in school because they're falling asleep all the time because they're not getting good sleep in the daytime. Older patients, adults who have obstructive sleep apnea, many of them are not aware of it, and they fall asleep behind the wheel of their car, and they put not only themselves but you and me at risk. If you're driving at 60 miles an hour and you fall asleep for only 4 seconds, guess how far you travel? The length of a football field. And in that distance, there's normally 3 or 4 telephone poles just lurking there, ready to smack you one. So obstructive sleep apnea can be insidious, but it can be very dangerous as well. In addition to poor school performance, behavioral problems are common, again, primarily due to sleep deprivation, but also due to the secondary effects of oxygen deprivation during sleep. High blood pressure, ultimately pulmonary hypertension, even congestive heart failure can result from obstructive sleep apnea. And again, it may not have been recognized for what it is unless someone is alert to the possibilities. So airway obstruction produces noisy breathing, snoring, shortness of breath with exercise. Obstructive sleep apnea can also cause wheezing if the obstruction is below the top of the chest, the top of the sternum. And severe obstruction can lead to respiratory failure. Simply can't get enough air in and out to sustain normal function. Now here is an example of laryngomalacia. As this child inspires, you see the arytenoid cartilages collapsing down over the vocal cords. Unfortunately, I don't have a soundtrack to this video. Wish I did, but this is a very classical form of laryngomalacia. This happens to not be a child with mucopolysaccharidosis. This is congenital laryngomalacia. This tends to get better on its own over the first 2 or 3 years of life. If it is severe to the point where it interferes with breathing, with eating, poor weight gain, poor oxygenation, etc., then our surgeons can go in and trim some of this excess tissue. They do so very carefully, very conservatively. That's called a supraglottoplasty, another one of those $17 words. And many of these children will get much better. Now, the problem in mucopolysaccharidoses is that many such children have laryngomalacia, and their caregivers, their family, and their physicians are unaware of it. And many is the patient I have seen over the years who develops symptoms of significant airway obstruction. They go to their local friendly ENT doctor who's probably never seen an MPS patient in his career, and he says, "Oh, you got big adenoids and tonsils, let's take them out." And guess what? He's completely unaware of what's going on at the larynx, and he intubates the child, does the tonsillectomy and adenoidectomy, and then the child fails to safely extubate. And he winds up getting a tracheostomy because nobody's understood what's going on in the airway. Now, here is a child with mucopolysaccharidosis type 2. And you see these retinoid cartilages are markedly enlarged. The mucosa is boggy and redundant and almost complete obstruction on inspiration. Now, you push a breathing tube through there for surgery, guess what? It's going to be hard to get that tube back out again. If you're aware of what to expect beforehand, you can avoid those complications. Now, my experience is biased, very much biased by my referral pattern. I only see the failures. I don't see the successes. A lot of kids out there in the world with MPS have safely had a tonsillectomy and adenoidectomy and nothing bad happened. But so many of them do that I wind up having to deal with that I would like to make people much more aware that there is a big potential for problem in this area. Here is another problem that we frequently see in MPS. This is a child who has a very excessive amount of lymphoid tissue. This is like the adenoidal tissue, but it's at the base of the tongue, and it can partially or almost completely obstruct the airway just by its physical presence. This can also complicate surgical management, airway management during surgery. Now here's a child who has 3 levels of obstruction. Big adenoids in the back of the nose. And when we turn the corner and go down to look at the larynx, we get past the adenoids. And oh my goodness, there's no larynx here. Well, you look carefully, there's the tip of the epiglottis down here, but this child has massive enlargement of the base of the tongue. So this child now has 2 levels of airway obstruction, the adenoids at the back of the nose and the base of the tongue. Now we're going to lift the jaw and try to pull the tongue base forward and look at the larynx. And here are the arytenoid cartilages. And now watch what happens as this child breathes. They get sucked in also. This child has laryngomalacia, has a big obstructive tongue base, and has adenoids. Removing any one of these 3 levels of obstruction is not going to affect the other 2. And it's imperative that you evaluate the entire airway in a patient who has any form of airway obstruction. A small percentage of patients that I have seen have had significant deposition of mucopolysaccharides in their trachea. Several of these I've had to treat by laser excision. It's not fun. Fortunately, it's rare, but I have seen a number of such patients. Here is the lower trachea in a patient who has this great big nodule of tissue here. This is actually, the trachea is compromised by about 3/4. We go past this, and there's the bronchus to the left lung. Here over here is the bronchus to the right lung. Fortunately, this process does not usually extend much below the level of the trachea, but it can be a very serious problem. There is a very serious complication that I've seen almost exclusively in type 2 hunters, and that is a deformity of the tracheal cartilages that is pretty characteristic. And I call it Hunter's tracheopathy, pathology of the trachea. It looks in many ways like severe tracheomalacia, but in fact is due to an abnormality of the cartilage. So here's this patient's larynx. The vocal cords look fine. The arytenoid cartilages actually look pretty good too. And as we go between the vocal cords and into the trachea, initially the trachea looks okay, but we get down just a little bit further and uh-oh, that doesn't look normal, does it? You see the deformity of the cartilage rings, the back wall of the trachea becomes extremely prominent. And as we pass down the trachea, you can see there's really very little airway. This airway is probably 95% obstructed. And yet this patient was somehow managing to function. Not very well, but functioning. And now here we're at the bottom of the trachea. This is the bronchus to the right lung. It's also flattened. This is the bronchus to the left lung. It is also flattened. I think I've seen this in one other patient who had an MPS but did not have type 2. Otherwise, it's pretty much limited to hunters. Typically, this begins to become apparent in early adolescence. I've seen it in a couple of 8 or 9-year-olds. The older people get, the more likely they are to have this. It is not universal, but it can be fairly severe when it happens. Many of these patients are treated inappropriately because they wheeze. There's obstruction in the lower trachea, and so on exhalation, the airway collapses even more, and they wheeze. And their caregivers, including their physicians, think they have bad asthma. And they treat them with asthma medications, and guess what? They don't get any better. And they get referred to me for severe intractable asthma. And if I know they've got hunters, the first thing I think of is they've got tracheopathy. These can be difficult to manage. These patients do not do well with anesthesia. If you put a breathing tube down there for some other surgery, you get just a little bit of swelling. You're going to further compromise the airway. You're going to stimulate more mucus production, and patients are going to be in big trouble very quickly. So what are our treatment options for patients who have airway problems in MPS? First of all, let me say that statistics do not apply to individuals. Everybody is different. Everybody is his own person. We had great hopes for enzyme replacement therapy. It seems to be more effective in general the earlier it is begun, but I have been singularly unimpressed at the ability of ERT to prevent the onset or progression of airway problems, at least in MPS II. Bone marrow transplantation, on the other hand, seems to be more effective. Again, this is best done as early in life as feasible. One of the most common problems, of course, is the large adenoids. I will tell you that I have had many patients, not just with MPS, but other problems, who need more than one adenoidectomy. If your child has had an adenoidectomy and he gets symptomatic again, the prime suspect is going to be recurrent adenoids. The adenoids are not a discrete organ like your appendix or your thumb, and they can and do grow back. I've had patients need 5 adenoidectomies over the course of some years. Supraglottoplasty, that is trimming of the excess tissue from the arytenoid cartilages, can be very, very helpful. One of the problems that we often encounter, particularly in teenage and young adult patients with MPS, is that due to the skeletal problems, it becomes almost impossible to get the normal instruments down to the level of the larynx. And so I've had to do a supraglottoplasty through the nose with the flexible bronchoscope using a laser fiber on quite a number of these patients. I prefer to have the surgeon or the ENT surgeons do it with rigid instruments if they can safely get there, and in most cases they can, but it's often the case that we have to do it some other way. Tonsillectomy, again, has to be done very carefully. Lingual tonsillectomy, removing that lymphoid tissue around the base of the tongue, and in some patients, a tracheostomy is required. This is particularly true in patients who have very severe Hunter's tracheopathy. And in this case, the tracheostomy tube has to be long enough to go through the entire length of the abnormal area of the trachea, which is usually all the way down to the bottom. So how do we diagnose these problems? Well, we take a good history. We have a high index of suspicion, our physical exam and x-rays. The best and most definitive way of doing this is by direct visual observation or bronchoscopy. I make it a point in most of my MPS patients, if I know they're going to the operating room for something else, I want to be there. One, to help the anesthesiologist make sure that the intubation is done safely and correctly, and that the extubation is done safely and correctly. And two, to get an updated view of the state of their airway and see if there's something we need to start really worrying about. The absence of symptoms does not mean an absence of problems. Too often in a patient's medical record, I read the initials WNL, presumed by the author, usually a physician, sometimes a nurse, to mean within normal limits. Unfortunately, all too often, what it really means is we never looked. I have been stunned many times at the disparity between what I see in the airway and what the patient's symptoms are at the time. But then they can fall off the edge of the cliff very, very quickly. So I like to take a biblical approach to bronchoscopy. Seek and ye shall find. Patients with mucopolysaccharidoses are the nightmare of the anesthesiologist, if they're smart. If they don't know anything about MPS, they don't know any better, and they're likely to have problems, and even more so, the patient will have problems. When you place someone under anesthesia, they lose muscle tone. You have to breathe for the patient, which means you have to have some means of delivering air, a breathing tube. And that in MPS can be a big, big, big deal. Many times it is absolutely impossible by conventional techniques to achieve a safe intubation in a patient because of the mandibular TMJ ankylosis, cervical ankylosis, et cetera. You can't open the mouth, you can't move the head back, and it can be very, very difficult. Again, my opinions are based on my personal experience, and I'm more likely to see the patient with problems. I don't know how many patients go through surgery without any problems at all. Probably the majority of them. But in my practice, guilty until proven innocent. Okay? Intubation can be very, very difficult, and the complications of intubation are legion, swelling, and then trying to reintubate again, particularly when it's all swollen. I've seen a number of patients who had a bedside tracheostomy when they were about to die because somebody had willy-nilly taken the endotracheal tube out, unprepared to put it back in again with special techniques. It is my personal recommendation, based on my experience with the bad end of the spectrum, the severe end of the spectrum, that patients with mucopolysaccharidoses, unless you clearly know that their airway is readily accessible with standard techniques, to be intubated with a flexible bronchoscope. At the same time, this gives us an opportunity to do a nice diagnostic evaluation. When we use a rigid instrument, we pass it through the mouth and we lift the tongue out of the way, we stretch the neck back. That's great if you can do it. But if you can't, then you use a flexible instrument that goes through the nose, goes around the corners, and finally into the airway. Anesthesia in these patients is not a task for amateurs or the faint of heart. Okay, this needs to be someone that is experienced with MPS. I would be very reluctant to see any of my patients have elective intubation at your local friendly neighborhood hospital. You need to be at a center where the patient can be given all the expertise and all the equipment available to us and expertise in their use. So if you're having elective surgery in a patient with a mucopolysaccharide disorder, don't do it in your local hospital. You might get away with it, but you might wind up being air flighted to some place like Cincinnati Children's. I don't want to see you that way, or your kids. Thank you.